Welcome back, and thank you so much for joining us, being a part of, we have our panel discussion now as part of Maine's Total Coverage Mental Health Awareness. We're so glad that the three of you could be here. The three of you bring a wealth of knowledge and three also very different perspectives in our broadcast right at 7 o'clock. Touched on a range of topics, but did so very quickly. And with an issue such as this, we want to make sure that we're really giving each of these issues the time to explore. If you're just joining us live streaming on Facebook or on WMTW.com, we really do want to hear from you. Please do write into us. You can DM us on Twitter or Instagram, and we will take your questions. I think a good place to start for us is stigma. This is something that we didn't talk about at our show. I think that we like to think that we've come a long way in thinking about mental health and mental illness, and this being something that we can talk about more openly and casually. But at the same time, I wonder if recent news events, in particular, we're always talking about the range of school shootings and violence that have happened, if that has set us back as we discuss about these issues. I'm curious what you think.
It's one of those things that we always want to be very aware of when we look at the news stories, when we look at information that's going out. What we know from the national rates is that only 3 to 4% of violent crimes have any sort of relationship or mental health related causes or concerns. But somehow we've linked that in our minds and in our society. So every time there is a high profile violent act, everyone automatically wants to make the assumption that it's mental health related. And again, what we know is that it truly isn't that. We know someone with a severe and persistent mental illness is 11 times more likely to be the victim of a crime than they are to perpetrate a crime. But again, we still continue to perpetuate that narrative.
And Carlene, I think that this leads into, well, you and I were introduced to each other when we were talking about the issue of involuntary commitment. And that in and of itself, this is a tough topic to discuss, but as we approach that and stigma with mental health issues, where do you think that we're at as a state, as a society in Maine when it comes to talking about these openly?
Talking about what specifically? Like being hospitalized?
Mental health broadly, whether that be being hospitalized for an acute mental health need or potentially a severe mental illness.
I think that we're more far ahead than we have been in previous decades. I think, and the fact that I'm here, that the voice of the lived experience is being listened to, that's a huge step also, but we still have a long way to go.
Long way to go.
Right?
Yeah.
The fact that it's still the fact that the story is still very lopsided, to include a lot of perspective of providers and the agencies and what they experience, and not doesn't include what it's like to actually go through that, be firsthand experience of that.
And Jayne, I know you have another perspective on that as well, saying earlier that behavioral health is your calling. And a question that I have as well before we start getting questions in from people joining us on Facebook and our website it has to do with the stigma of trying to bring up the conversation with somebody and how you can go about that, because I think a lot of people may wonder or see somebody struggling but not really know how to bring up that topic in a way that is concerning but not judgmental, and how you can navigate that.
Sure. I think it's important to remind people that this really does impact everyone. It's everyone's family, everyone's coworker, everyone's neighbor. And to disclose your own family's involvement in a substance use disorder or a mental health illness, I think makes it a safe space for someone else to also talk about that. You want to question them, you want to persuade them and refer them to professionals.
And we were talking earlier too, just about how you know who to call in a situation, right? A lot of times, as we were talking about in our special, it's very tempting, we're all very well trained. Pick up the phone,
Absolutely.
Call 911, but a call to police, law enforcement, 911 may not be the best phone call to make.
It may not be.
How do you know who to call?
We would recommend that folks start by calling the crisis line. And the crisis line is available to give support 24/7, to give advice, to come out and meet folks where they are, and if they feel it is a police matter, they'll say that and recommend that, and then hopefully a CIT trained police officer will respond.
Are we in a difficult position? We always like to say that help is always available, and we do have great resources through the Maine Crisis Line and the National Suicide Lifeline. One of the things that you've talked about is that there are long and persistent wait lists, shortage of beds to find these services. So we have that entry point, but it seems like we are struggling right now to create that sustained wraparound care.
Absolutely. So our crisis staff will follow up with folks a month later, check in on them, make referrals, but there are long waits for services in Maine. There just really are. And it is a workforce issue that we do need to address as a community and as a state.
And for people who didn't see perhaps our on-air special, the wait list right now at Sweetser, I know we've been, it's just so stunning to me that 2,000 people are on that wait list right now looking for that help. And why is that? How did this list get so long?
Well, I think that there is a lack of psychiatrists, there's a lack of nurse practitioners. In this country, 60% of the psychiatrists are over 55 years old. So we're on the precipice of a retirement cliff. So we have that. We do not have enough therapists. We don't have enough social workers. We don't have enough LPCs. I do think we need legislative intervention in terms of tuition breaks, in terms of student loan forgiveness. And as we talked about before, making it easy and seamless to come to Maine from another state to work. It's a beautiful state. People will come here. We need to engage them and make it really simple.
So are you saying it's not easy to come here and start working in Maine?
It's not easy.
Yeah. Why is that?
It takes a long time. There's a lot of bureaucracy involved, and it takes a long time. We've had staff that had to wait for months. I've had staff that I've paid, but I couldn't bill because they didn't have their license. And the same thing, people who graduate, we really need to reduce the time once they graduate to when they have their license, and make that as short as possible.
Carlene, I'm curious through your work as an intentional peer support specialist, what you're hearing from people. I know that it's difficult for a lot of Mainers to even find a primary care physician, let alone initiate the process of finding mental health care that they're looking for. What are you hearing through your contacts? Are they able to tap into the services that they need, or does this remain a struggle?
It is a struggle to be connected, and I think it's a struggle to even know how to find services in the first place. Just something as simple as there's a phone number, here's this agency, here's a phone number, you call it, it goes to voicemail, or it goes to a phone tree, and it gives you all these options, and that's a barrier in itself, especially if somebody has a cell phone that doesn't have very many minutes on it and they have to save it. Right. So there's a lot of parts to the problem, and there's no one fix to it, like throwing money to give more services. It's like, well, where's this money going? Because right now we're seeing that people are still without help, and it's
Is this where we all have a role to play? I know through NAMI Maine that you offer mental health first aid. In the absence of the services to meet the needs and the growing needs of all Mainers, is there something that we can do, something we can learn to serve our peers and know how to help and when?
Absolutely. Again, mental health first aid provides a really easy way to just say, I'm worried about you. This is what I'm noticing. I'm worried about you. I care about you. What can we do to support you? And really starts to break down. Again, one of the things I love about mental health first aid is when we talk about the stigma and we talk about the need for resources and legislative issues, it's the parity. Our physical health is just as important as our mental health. So if we have basic first aid and CPR, then we should have mental health first aid CPR. And how do we just, again, recognize that someone's struggling and know how to support them?
I want to get to a question that we did get from Facebook just minutes ago from Sharon. She's saying, I was recently at a legislative hearing in Augusta about residential facilities for young adults. The general consensus is that there are beds, but not enough staff, so the beds go unfilled. Does that speak to the shortage that we were talking about in providers, or is there something else at play here?
I think here they're probably talking about direct care kind of staff, and there is, they are hard to recruit. For Sweetser, what we see is that we don't have the psychiatric residential treatment facility level of care, which is a higher level of care. Our residences are open, so the kids can run out the door, can run away, and there is a need for a level of care that's still clinical. It's not a forensic setting, but that it is locked. And therefore, we can keep these kids safe. Right now, Maine has about 60 kids being served out of state. These kids need to come home.
And we've talked about early intervention and what can be done at the school age level. One of the things that I've heard just as a parent is this concept of resilience building and trying to teach kids at a young age how to identify if they're struggling, what they can do. Is that something, have each of you explored that through your work?
Certainly our program, which is our school-based therapy program, they teach coping skills, they teach resilience, they teach children as young as first grade, really how to deal with the struggles that they encounter on a daily basis. So it is something that's part and parcel of what that program does, and it is preventative in nature. The more we can teach those elementary kids those skills, the less likely is they'll become our adult patients.
Right, and I think that would be the hope, that maybe the model shifts into treatment for adulthood. Carlene, when we've chatted before, I think that we've talked about other levels of treatment where there's more of a community-based approach that's either a group home or more residential casual setting where adults are there to support each other. Is that something that you could explore?
As an alternative, like for example, a peer respite.
That's
Not
that's
like
the term I was
a
searching
mental
for.
health component.
Right.
That would be a great option to have in the community for an adult. And going back to the children's what you're talking about, I hope it's done in a way that doesn't like further pathologize what they're going through, and it validates what they're going through, because I'm sure kids today, especially through COVID, having to stay at home with parents and parents being stressed out with jobs, there's a lot going on, environmental factors. So I hope that's an important thing to focus on. So it's not all like what's wrong with you, it's what's going on, what's happening.
Absolutely. And what's important to you.
And I think what we've seen is mental health issues impact really every age, every demographic, every income level. And one thing that's very important to me is veteran suicide and what we can do in that area, something that we haven't talked about yet here tonight, but there are statistics that show in 2020 more than 6,000 veteran suicides, average about 17 veterans dying a day to suicide. So I mean, just coming off Memorial Day weekend, how do we lower that? I mean, I think that those are some of the questions, that we talk about. And Hannah, I know you have some firsthand experience with this as well.
Yeah, when we look at the veteran suicide rate, it's really what we really look at and what we take into account is the fact that only about 30% of veterans who die of suicide are connected to any formal system.
Oh, wow.
And when we really look deep into the statistics, they're connected to peer support groups. They're connected to their spouses. And so when we look at the veteran community, peer support is so incredibly critical. We do work with employment. We do work with a lot of alternative. And really looking at it and changing the narrative, again, not what's wrong with you, but what's happened. And making sure that we're not viewing them, and as society can sometimes when we really look at the stigma, as having something wrong with them. It's a medical condition, the same as if, and I always liken it to, if you hurt your knees when you're on deployment, we're going to take care of you. If we hurt your central nervous system, we're going to help you.
So when you say 30% are connected when they return from service, that means 70% of veterans are alone with no support, no resources. Am I understanding that correctly?
Not that they're alone with no resources, they just don't necessarily have formal resources for a lot of different reasons. I will say that our VA system here in Maine and across the country is making a big push to make sure that they are recognizing and pulling in as many veterans as possible. There's the post 9/11 care office just at the VA in Togus. It's a wonderful resource and works with a lot of great veterans, but a lot of them, for various reasons, may choose not to access different services that are available to them. And that's when we really want to look at the fact that over 40% had spoken to a coworker or someone at their work. A lot of them had spoken to their spouses. And so a lot of our interventions in our work are really on how do we use mental health first aid, a veteran model of mental health first aid, and other trainings to bring awareness to those natural supports in people's lives. We overlook those natural supports and the importance so much.
How important is it for a veteran to have continuous care with a provider that they're familiar with for a long period of time? So I've heard that one of the challenges is that a veteran may enter the VA system, they have a provider for a couple years, they're reintroduced to a new person, and in a way, it almost sounds like they're re-experiencing some trauma in sharing that story again to another provider, and you're starting from square one.
It can be incredibly difficult. We look at evidence-based treatment, the best practice for how do we treat someone who's struggling with their mental health, and we have that, but we also know that a large part of the success is the relationship that someone has with their treatment provider. And I always encourage everyone, when you start treatment and you start your treatment journey, make sure you're starting with someone that you have a good connection with. I know as a clinician that I'm not everyone's cup of tea, and that is completely fine.
I can't imagine they would say that.
Well, you know, and so, you know, making sure that there's that connection and that rapport, and I know that it's not always possible. And
Right.
the VA, you know, it is a federal system, and it can have turnover. There's a lot of different competitions with different agencies for providers as well in the state.
And I know that we've been driving a lot of this conversation tonight, but the three of you are in this every day, and that's why we invited you here. And again, thank you for being here. But what are we missing? What are the questions that we as journalists, as we as a station, trying to raise awareness on this issue? What's underreported, and where should we be focusing some of our resources and our attention?
Well, I love the fact that you did this program, and I think it was really well done, so I commend you. I do think the media can really help with, you know, the stigma that exists. If you go back 30 years, what did people think about behavioral health? One flew over the cuckoo's nest. That's what we thought about. And still to this day, you know, Halloween doesn't go by without a movie about a psych hospital, rarely. So I think these kind of programs are critical in terms of addressing the stigma, and let's call it what it is, discrimination that exists against people that have behavioral health disorders. So, you know, I think just highlighting the athletes, the actors who've been brave enough to come forward, Adele with her depression, you know, Michael Phelps with his ADHD, Chrissy Teigen with her postpartum disorder. There's a slew of folks who've stood up and said me, and it is everyone's family.
Yeah.
So.
And I almost want to challenge that, because no one hesitates to stand up and commend actors who say that they're struggling with insomnia or they have a hurt knee.
Yeah.
Mental health affects all of us, and I think that the more we can step back and recognize we all have mental health and we all have physical health, and we should treat them exactly the same.
Absolutely.
And
they open the door. They do open the door.
They do
and
open
make
the
it
door.
easier for other people to say me too.
And I would love for us to see the day that we don't commend them, that
And-
it's just normal.
And Carlene, from your perspective, what would you like to see in the conversation?
I'd like to see more voice of people who've been on the other end of these services that everybody's talking about that are so great. It's like I'd rather hear from the people that have experienced it to see, is it really great? Is it helpful?
Right.
Because that's how you learn.
And I've been keeping an eye on my phone just to look at questions in case you're wondering why does he keep looking at the phone. But I want to get to one more question here. Do you believe barriers to care for mental health treatment are high cost insurance coverage or no insurance coverage at all? And I don't know who would be best to answer that, but definitely a difficult question. When you talk about payment, you know, many of these services are expensive. There's waiting lists, and people need the help. But of course, the concern is, how am I going to pay for it?
And I think, as you mentioned before, you know, we have made some strides with parity. Our co-payments are the same. Our lifetime limits are the same. What's not the same? The size of the panel is not the same. So even if you have insurance, you're at a network, you know, 60% more of the time with behavioral health than you are with medical care. So there is a financial burden for these services.
Also looking at it as specialty care. If you went into an intensive care unit at the hospital, the nurses there and the providers there, it's not considered the same. It's not looked at the same. When you looked at a residential treatment facility, again, it's not looked at the same. When you look at peer support at at different centers for medical conditions. It's not looked at as the same, and it should be, and that's where the problem is.
But it's not the same. That's the thing. It's like it's not a medical condition. There is no basis in science for this. So you can't, and there's no one size fits all treatment for mental health. So that's why the comparison, I mean, that's part of why comparison to medical problems that's problematic.
I did love what you said about, nothing about us without us. And I do think the voice of peers need to be embedded into every organization that provides behavioral health.
We have just a few minutes left, but I want to talk about some recent polling that I saw just today that has to do with depression in the workplace. It's about 1,100 people, American workers across the country. 34% said that they were afraid to go to their supervisor and say, hey, I'm struggling with my mental health. Is that something that you think needs to change, where somebody can talk to their boss and say, I need to get some support here?
I think because I've read stories about how people have ended up in the hospital because their boss or whomever has made the decision, like, I'm going to make a call, and they end up, worse than they
just removes
were.
their
They
agency.
just wanted to talk, right?
Yeah.
Yeah, maybe something's going on at home. They just need to talk about it with the boss, but there's this like stigma and this fear around it, and it leads to more of a knee-jerk reaction.
I mean, when you think about it, how would you feel about calling your boss tomorrow and saying, I'm depressed, I'm going to take the day off? You're going to say, I have a stomach ache, or I have the flu. I mean, that is the stigma that still exists today. I mean, we should be able to take mental health days. We all need them. We all need them.
Prior to COVID-19, the World Health Organization said that depression and anxiety were the leading cause of economic loss.
Absolutely.
Stunning. Well, the conversation, we were just starting again our partnership with NAMI Maine, kicking off, so you can look for much more coverage throughout the next year of stories pertaining to mental health awareness. And of course, to Hannah, Carlene, and Jayne, thank you for taking time out of your evening, dinner time, in fact, to be here with us and launch this conversation.
Thank you so much for being here. It's great to talk to you all.
Thank you.
And thank you for being with us on Facebook and on our website as well. We certainly hope you have a great night, and we'll see you soon.